Wonderful. Thanks everybody for joining us again today. It is my sincere pleasure to welcome Dr. Alfred Abuhamad, a person who needs no introduction in the field of perinatal imaging. I always learn a lot from his lectures, and Dr. Abuhamad, who is professor at the Eastern Virginia Medical School, is joining us today to present a talk on fetal renal malformations, the role in ultrasound in diagnosis and management. Dr. Abuhamad, thank you again very much for joining us today.
Thank you very much, Bill. It's really a pleasure for me to give this presentation. My apologies for the delay in getting my laptop set up. So during this presentation, I'll briefly talk about embryology, probably one slide, just to introduce the concept of renal malformations. I will share with you some information on the role of the first trimester ultrasound in screening for renal malformations, and I think that's an evolving field. I just wanted you to be aware of and wanted to kind of pique your interest about the usefulness of such. And then I'll present renal anomalies. This is a big topic and there's a lot to talk about. As I put this talk together, I ended up with about 150 slides, but do not worry, I'm not gonna share all that with you. So I created a redacted presentation, but there's a lot of information to go through. So I'll try to give you what is really relevant for you as an MFM fellow in seeing those patients in the ultrasound units. So briefly, embryology, initially things start with the pronephros, about the third of the fourth week. That kind of disappears fairly quickly around the fourth week. Then the mesonephros comes about, as you see right here. This gives rise to the ureters, renal pelvis, and the trigon. And then from the mesonephros, development of the mesonephric duct comes about. That is really important in developing the renal system. And then a metanephric system is developed around the same time that contributes to the kidneys, and with the mesonephros gives the GU system as we know it in the fetus and in adult life. So how important is the first trimester? You can see the bladder fairly early in ultrasound. I would say consistently about 13 weeks and onward, you should see the bladder. At 12 weeks, you will in the majority of fetuses. And my best approach is to do an axial view in the pelvis, as you see here in these three fetuses in the first trimester. Color Doppler is also very helpful to localize the bladder in case you can't see it very well, as you see here in this 12 weeks fetus. So the bladder is seen in about 88% at 12 weeks and close to 100% at 13 weeks. Certainly, if you have optimal imaging, that is the case. What's really important to note also here is that the source of amniotic fluid is not totally from the kidneys until about 15 to 16 weeks of gestation. So what that means is you can have bilateral renal agenesis with normal appearing fluid at 13, 14 weeks. Or you can have a bladder outlet obstruction with what looks like normal fluid at that gestation. So keep that in mind because assessment in the first trimester is certainly related to this important concept in amniotic fluid formation. I wanted to share with you also, as part of the first trimester imaging, the mid-sagittal view of the fetus, which is a very important view, and more will come in the future about the role of this view in the evaluation of the fetus in the first trimester. But I wanted to discuss with you the sagittal length of the bladder. So the normal bladder length is less than 7 millimeters in the sagittal view in the first trimester. So if the measurement is between 7 and 15 millimeters, this is called megacystis, just an enlarged bladder. There's a high association with chromosomal anomalies in about 24%. If the chromosomes are normal, however, this is a fairly reassuring finding. Resolution is noted in about 90% and only 10% have renal anomalies. If the measurement is, and this is a patient that shows you at 12 weeks, with a 12 millimeter sagittal view of the bladder on follow-up ultrasound, as you see, the bladder is normal thereafter. Even there's a hint of what looks like a keyhole appearance even here. If the bladder is actually larger than 15 millimeters on the mid-sagittal view, chromosomal anomalies are a little bit less common, about 11%, but almost all these babies will have renal anomalies upon follow-up. So keep that concept in mind. The measurement of the bladder is really critical. This is the same fetus with the silhouette mode and showing you the bladder within the abdomen. So how about kidneys in the first trimester? You can see them. You see them in the same axial views that you see here around 11, 12, 13 weeks. In my opinion, the most optimal approach is through a coronal view, as you see right here, because then you eliminate the shadowing, and the kidneys are a little bit more echogenic in the first trimester than they are later on. And you could see right here, and you can see the adrenals on top of the kidneys. If you have access to a transvaginal ultrasound, that certainly enhances visualization of the kidneys. They look a little bit more echogenic, so don't get fooled that these are abnormal. This is how the kidneys would look early on in gestation. So the kidneys are seen again almost 100% by 13 weeks onward in the first trimester. How about fetal gender? It's inaccurate before 12 weeks. The accuracy increases with advancing gestation. Should be able to determine gender almost always at 13 to 14 weeks. Let me give you a tip, an ultrasound tip that is really helpful if you're looking at gender in the first trimester. So if you look at the genitalia, the female genitalia is actually parallel to the long axis of the fetus, parallel to the spine. You see how the orientation of the genitalia and the fetus, in the female fetus in the first trimester, whereas the male fetus genitalia is perpendicular to the spine. So these are important clues. Sometimes this is important, especially for X-linked diseases, to determine the gender early on, and this is an important trick to remember as you look at that on ultrasound. Second and third trimester ultrasound, as you know, the kidney has its corticomedullary differentiation. Now you see the pyramids surrounding the renal sinus, and the renal sinus is a clear, like slit-like appearance, as you see right here in these two normal fetuses. Renal artery is important to determine if you are suspicious that the kidneys may not be in their location or with aplasia. I wanted to share with you that having a double renal artery is not an uncommon finding, and it's actually fairly common, and it's considered normal variant if the kidneys appear normal in size and in appearance. If the kidney is abnormal, as we discussed when we talk about horseshoe kidney or cross ectopia, then having multiple renal arteries may be helpful in your diagnosis. So I wanted to figure out a way to do the classification of renal malformations. And actually, I struggled a while to figure out how to do this because there are different ideas and there are different presentations. But if you look at the cell biology of these malformations and look at the genetic origin, I think you may come up with three big categories. You come up with urinary tract dilations, aberrant early development, meaning the early development of the kidneys did not go the way it should be, or after the kidneys have been developed, there is some terminal maturation issues that resulted in some defects. Now, although there are kind of distinct, there's significant overlap between them. And what I want you to focus on is that spectrum with significant overlap. So what looks like a dilation, you know, on ultrasound, if it is severe, can end up with a lot of dysplasia and so forth. So I tried to put all the renal anomalies on this list to show you that you may have a urethral atresia, and that's an obstruction issue resulting in dilation, but then that obstruction leads to a lot of developmental problem with multicystic dysplastic kidneys and so forth. So there's a continuum of overlap between many different abnormalities. Keep that in mind as we try to subclassify them into distinct categories. So let me start with the urinary tract dilations. And on this list are the UPJ, UVJ obstructions, the reflux, the LUTO, the lower urinary tract obstruction, and some other syndromes, Crohn belly, and so forth. So let me start by, and I tried to kind of format the presentation by giving you what you see on ultrasound. So you're scanning and the patient has a dilated renal pelvis, could be unilateral or bilateral. The ureter is not visible. So I placed on purpose distal ureter because the proximal ureter could be dilated in UPJ obstruction, but the distal ureter should not be, and the bladder is normal. So if you have this combination, frankly, what could be is the list that you see right here. This is what we refer to as a uteropelvic junction obstruction. And in uteropelvic junction obstruction, this is a nice schematic from CHOP, from their website. You see dilation of the renal pelvis, but the distal ureter is normal in size. Keep in mind, though, that these dilations that we see on ultrasound prenatally most of them are actually physiologic. There's no anatomic obstruction. And why is that? There's some suggestion that the effect of maternal hormones in pregnancy, such as progesterone, dilates the fetal urinary system, and also overhydration. And I'll show you the effect of overhydration on dilation of the renal pelvis. But if there's an anatomic reason, it's usually a ureteral stenosis or obstruction by an overriding vessel, and that's more common on the left side than the right side. We did a study several years back, actually. We got pregnant women that had renal pelvis dilation and those that did not, and we scanned them initially, and then we hydrated them. And what you could see that in every single patient, actually, we were able to increase the size of the renal pelvis. And in about 20 to 25% of the normal population, the normal pregnant women, we were able to induce dilations that crossed the threshold of 4 millimeters. This was in the second trimester. So the effect of hydration is real on making the renal pelvis more dilated. So could we actually differentiate between a truly obstructive uretero-pelvic junction obstruction or a physiologic one from the presence of excess, either hormonal or overhydration? I would say in general, no. However, if you have more dilation of the renal pelvis, the larger it is, certainly if you have calyceal involvement and if you see progressive worsening as you follow up those patients, that tends to be more of an obstructive nature rather than a physiologic nature. So if you look at all urinary tract dilations here, what I'm talking about is the uteropelvic junction obstruction plus the physiologic type accounts for almost like 80% of all the dilations that you will see in your practice prenatally. So what is exactly a dilated renal pelvis? The Urology Society, the Fetal Urology Society, put a group together about 2 years ago, I think 2014, and defined it by less than 4 millimeters at 16 to 27 weeks, 7 millimeters at 28 weeks, and 10 millimeters postnatally. I don't want to go into details on this. I would recommend that you read this paper because it's a national classification that has been approved by societies, and that's what should guide your clinical decision making with regards to when do I see the patient. And there are subcategories also involved in this that allow you to classify those into 1 or 2 or 3. So let me focus on uteropelvic junction obstruction. It's the most common thing you will see. There's a little bit of a male to female ratio of 2 to 1. Most of them are unilateral, and most involve the left kidney, probably related to the drainage of the left kidney, the way the left kidney drains into, because of the vessels that exist on the left kidney versus the right kidney. And there's a small association with extrarenal anomalies, so you got to look into that. I probably should turn my, let me do this one thing here. Sorry about the background noise. Okay. So now some important factors about the UPJ obstruction. So sometimes you see fetuses like this where there's a lot of renal pelvis dilation, but you don't see many dilations inside the kidney. So the calyceal system is not dilated. I think the more internal renal dilations that you see, the higher is the risk for a loss of function afterwards. So the external dilations, frankly, don't bother that much as long as the calyceal system is not dilated. So keep that in mind. However, if you see progressive changes during pregnancy, as you see in this patient between 23 weeks up to 32 weeks, that is a poor prognostic sign. And that is something that you should be worried about because of loss of function and certainly the need of surgery afterwards. Can UPJ obstruction resolve spontaneously? In the majority of cases, yes, if they are mild. And certainly severe cases will show some improvement in about 70 to 80% after the fetus is born. Now, could we predict the need for surgery on prenatal sonography? Well, the answer is yes if you go to the extremes. For instance, studies have shown, and this is a nice study that I like because they looked at different cutoffs, but if the fetal urinary tract dilation is 18 millimeters or greater, or if the neonatal ultrasound shows a 16 millimeter or greater dilation, that has about 100% sensitivity to predict postnatal surgery. So in counseling patients, I typically tend to be very optimistic until you get to 15, 16 millimeters in renal diameter and renal dilation prenatally, because a lot of those that are less than that will probably do quite well postnatally without the need for surgery. So if you have loss of function or if the function is low, would surgery successfully improve it? Would they recover? At least the data that exists today suggests that it is unlikely to recover function that you've lost prenatally. However, the surgery is really essential in those large dilated kidneys to preserve whatever function exists at that time. So keep that in mind as you counsel patients. I think that may become an important point. So now you have a dilated renal pelvis, plus or minus calyces, but the distal ureter is dilated, as you see in this clip right here, but the bladder is normal. And you see here the dilation of the ureter all the way with a normal bladder. Here you got to think about UVJ obstruction, you got to think about reflux, and certainly you're going to think about a duplex kidney. So in a UVJ obstruction, what you will see, it's an obstruction at the level of the bladder with a dilated ureter and a dilated renal pelvis. The other etiology could be just a mega ureter, and there are some classifications of that. I didn't want to go into details in the interest of time. Certainly, vesicoureteral reflux is quite common, and duplex kidney I will expand on and discuss in more details. So now if you have a dilated renal pelvis, a dilated ureter, but also an abnormal bladder. Abnormal bladder could be a thickened bladder, as you see right here in this ultrasound image, or it could be a massively dilated bladder. Here the idea is there is a lower urinary tract obstruction, so either primarily due to posterior urethral valves that tend to be the most of what we see prenatally, but also could be urethral atresia, and I'll show you how to differentiate between the two. Urethral stenosis could be the case, Prune belly syndrome, cloacal dystrophy, and megacystin microcolon. I'm not going to cover those because of the interest of time. I'm going to focus my discussion on the posterior urethral valves. So in posterior urethral valves, you see a dilated renal pelvis with dilated calyces most of the time, dilated ureters primarily bilaterally, and an abnormal bladder. Here on the clip, you see a thickened bladder here that is quite abnormal, but also on the still images, you see a large bladder with what a keyhole appearance looks like. And I put this on purpose with inverse mode just to show you how the keyhole appearance looks on ultrasound. So this is almost diagnostic of posterior urethral valves, especially if you have a male fetus. So the ultrasound findings include megacystis, an enlarged bladder, thickened bladder wall, which is defined greater than 3 millimeters, by the way, a keyhole sign, which is a dilated posterior urethra, bilateral hydronephrosis, and oligohydramnios. Now, how do I differentiate a posterior urethral valve from urethral atresia? In general, urethral atresia will not have a keyhole sign, will have a massively dilated bladder without a keyhole sign. So the presence of a keyhole sign on ultrasound is actually helpful to help you differentiate posterior urethral valve from a standard just urethral atresia or severe stenosis. First trimester, you see those pregnancies often actually. You could see here in this first trimester in this fetus, you see a massively dilated bladder. You also see renal pelvises that are dilated here, and you see the keyhole appearance. And this is a 3D showing you dilation of the abdomen. What you see also is that there's normal amniotic fluid volume surrounding this fetus because we're less than 15, 16 weeks, and that's not an uncommon finding. So how should we evaluate those patients? So certainly detailed ultrasound, right? You're going to look at everything else to make sure there are no associated anomalies. You do an amniocentesis if there's fluid, but if not, you can culture the cells from the bladder. They take a little bit longer. Vesicocentesis. Here you do a microarray. That would be my recommendation. Then you assess the kidneys very closely. Here we're looking at size, echogenicity, and the presence or absence of cortical cysts. Take some urine to evaluate for prognostic indices. Experts recommend that you throw the first urine out and then take a urine sample 24 hours later by through a vesicocentesis and assess those. And certainly the comprehensive counseling. I'm going to try to guide you on this through this talk because this is not an easy task to do. So one thing to remember is sometimes the bladder can rupture. And this is a patient that we scanned recently. This is, I think, like last month. And you could see here the ultrasound, and the fellow was scanning her right here. And you see the ultrasound is really massively dilated. Jennifer was scanning her. And then during the ultrasound, you see the bladder ruptured. And now the fetus had ascites right during the ultrasound, just several minutes after that. So this could happen. It's uncommon, but could happen. Keep that in mind. The big question is, how good are we in predicting prognosis prenatally? So when I see a patient with a posterior urethral valve, can I really sit with the couple and get some urine and look at the ultrasound kidneys and say, I really think your baby has good or bad prognosis? So let's go through this. First, you look at the kidneys. So what I'm looking for is obstructive cystic dysplasia. Here, what I'm looking for, kidneys that are small, that are echogenic, that have cystic changes. As you see right here, they are peripheral cysts, and these are not calyces, so don't make that mistake. You see right here, and look at this bright echogenic small kidney that you see here. And this is a small kidney with an abnormal cyst, as you see right here. Certainly, the presence of oligohydramnios is extremely worrisome in that condition. Well, these are has been described as diagnostic, at least as prognosticating factors for poor prognosis for patients. How about the urine itself? When we send the urine for analysis, commonly it's sent for these that you see in this table right here. And what we are looking for is we're looking for kidneys that cannot retain salt, kidneys that are losing salt. And so the higher the sodium chloride, osmolality, and so forth, the worse is the prognosis. I could tell you that here's the statistical performance of these parameters that many times we put a lot of weight on. See, sodium, osmolarity, even beta-2 microglobulin have very poor sensitivity and specificity, frankly, to predict pregnancy outcome. And this is a paper that looked at 23 articles, a total of 572 women, looking at could we predict renal function by looking at these fetal urine analysis. And basically, none of the analytes investigated so far can be shown to yield clinically significant accuracy. So keep that in mind, even though we put a lot of emphasis on doing vesicocentesis and we stratify patients for those who would require intervention and those who don't, we don't have a good evidence regarding that. So if I summarize, how good are we in predicting prognosis by ultrasound and electrolytes? We're marginally predictive of poor outcome. So I would not personally put a lot of weight on how the ultrasound looks or the urine electrolytes in making major decisions with regards to management of those pregnancies. There is some hope, however. There's a recent study that was done 3 years ago that looked at urinary proteins, 12 urinary proteins, and showed that improved prediction of renal function in pregnancies with lower urinary tract obstruction. That has not, to my knowledge, is being clinically available at this stage and certainly needs more validation. However, if you have a patient with a normal amniotic fluid volume and the diagnosis happened after 24 weeks, we have a lot of evidence to suggest that these patients will have a good outcome and they will have fairly good renal function upon long-term follow-up. So the negative predictive value is fairly good. The positive predictive value, I think, is not for these ultrasound markers. So how do you intervene with those patients? You either put a shunt, vesicoamniotic shunt, and some centers are now doing fetal cystoscopy and doing laser of the posterior urethral valve, or in the presence of urethral atresia, trying to relieve that obstruction. So how effective is shunting as a therapeutic intervention? If you look at the data with regards to perinatal and postnatal survival, you see that overall, whether you are in a good or a poor prognosis categories, and these are the number of studies you see on this forest plot, that overall, it seems that putting a shunt in between the bladder and the amniotic fluid tend to improve survival for the fetus and for the neonate afterwards. However, a lot of studies suggest that the renal function is probably marginally improved at best long term. And I think the reason probably why survival improved because of the reducing the complication of pulmonary hypoplasia in many of those pregnancies. So the impact on renal function is probably not as strong. And most of those pregnancies that you see and you treat with a shunt will end up with significant renal dysfunction, as you see right here, about a third with dialysis or transplant, and about 22 with mild insufficiency. Now, what happened with the cystoscopy? Is fetal cystoscopy better? Well, there is some evidence that suggests it is probably better, but I would be very cautious because we don't have a lot of data yet. This is a study that evaluated the intervention of conservative management versus vesicoamniotic shunting versus cystoscopy. And you see that for both interventions, there was a statistically increased survival. So again, survival, babies would survive better, but only cystoscopy improved renal function in cases of posterior urethral valve. Another recent study in 2016 looking at 50 fetal cystoscopies, you could see that in that study in year 1, 56 survived, 75 had normal renal function, which is really impressive for such severe anomaly, and in year 2, 73% had normal renal function. So I would summarize here by saying that vesicoamniotic shunting and cystoscopy improve survival over conservative management. There's no question. I think we have enough evidence to kind of support that. Long-term impact on renal function is still poor with the vesicoamniotic shunt or with conservative management, and a substantial number of those children will end up on dialysis or on the renal transplant list. And there is some evidence today, at least by the two studies that I've shown you, that cystoscopy appears to improve long-term renal function. But I would recommend that we get more robust data before we jump on this and start doing cystoscopies on all those patients. So we're finished with the urinary tract dilations. I'm going to move into the aberrant early development. And here what I mean is we're going to talk about duplicated renal collecting system, renal aplasia, renal fusion disorders, and the multicystic dysplastic kidney. So duplex kidney, double kidneys. A duplex kidney has two pelvic calyceal systems, as you see right here. The upper pole is typically about a third the size of the lower pole, as you see in this nice schematic drawing. Most of them are probably uncomplicated, but most of the ones we see prenatally are complicated because we make the diagnosis based on either a dilated ureter or a ureterocele in the bladder. So keep that in mind. So when they are complicated, what happens? So the upper pole right here typically has a ureteral ectopia, meaning that the ureter does not open at its anatomic location. Most of those are at the bladder neck, but could be any place. Could be in the vaginal canal, could be in the uterus, could be in the urethra. So there's a lot of variations to that. But typically you see a ureterocele, which is related to the obstructive nature of that ectopic ureter on this state. The lower pole, on the other hand, is commonly associated with vesicoureteral reflux, and then you see some renal pelvis dilation associated with that. So, sorry, not my technical day. So what you see then, the most common location, as I mentioned, is the bladder neck, but can be anywhere in the genital tract. This is where the ureter ectopia is. And then there is an association, and this is an important, there is an association between the presence of dysplasia and the more ectopic the ureter is. So if you have a ureter that opens in the vaginal canal, there is more association with ectopia. And this is a nice case of a duplex kidney with an upper pole that is multicystic dysplastic and a normal lower pole. When I see this, that implies to me that that upper pole has an ectopic ureter that is really probably outside of the bladder. So what are the findings that you see? Several years back, and I'm dating myself here, we did a study on a number of fetuses with duplex kidneys to define what you see prenatally. And these are the criteria that you should follow. The sagittal length of the kidney would be enlarged, certainly because you have almost double kidneys. There's a cyst-like structure in the upper pole. In my experience, this is the most important factor for you to identify those. I'm going to show you a lot of cases. There are two separate renal pelvises that you see. There's a ureterocele in the urinary bladder, and the distal ureter, usually from the upper pole, is usually dilated. So let me show you some examples. So here you see, when I look at this ultrasound and I see this cyst-like dilation right here, I'm very suspicious of the presence of a duplex kidney. And look right here in the schematic drawing, you see right here, and this looks to me immediately like a duplex kidney. This is the lower pole pelvis, that's the upper pole pelvis. And then I'm gonna go to the bladder because I think there is a ureterocele also attached with that. So that's the first clue to your diagnosis. The second clue is a dilated ureter. So here you see there's a duplex kidney clearly, and there's a dilated ureter that looks like, on cross-section, like multiple cystic structures between the bladder and the kidney. And these are how ureterocele look on ultrasound. So this is a double ureterocele in the bladder, here with color showing you inside the bladder, and here on grayscale. Keep in mind two important factors about ureteroceles though. First is that ureteroceles in the bladder could be your first clue to the presence of a duplex kidney. Second, that if the bladder is really full, and that's more of an issue postnatally than prenatally, the ureteroceles can collapse and you may not see them. And on occasions, you may have to resort to a transvaginal ultrasound to see those. So keep that in mind. So let me go quickly through the other problems in genesis of the kidney. So bilateral renal agenesis, you would see on ultrasound anhydramnios, empty renal fossa, and on your color Doppler, or you won't see a bladder typically here. And the adrenals are flat in appearance, and many of those fetuses have hypertrophic cardiomyopathy that you could see. In the first trimester, this is easily seen also, but there's associated normal amniotic fluid, remember. So here you see there's no bladder between the two umbilical arteries. And here's a flat adrenals. Again, these are present even early at 12 weeks in 2 fetuses with bilateral renal agenesis. In unilateral renal agenesis, it's similar to bilateral, but there's one empty fossa on one side. Here, it's really important to make sure that the kidney is not in the pelvis or somewhere else before you make that diagnosis. So you'll have a flat adrenal on that side, and there's some associations with problems on the other kidney. These babies are not, so when you counsel the parents, I usually tell them the outcome is really good because there's normal fluid and the baby will do really well. But keep in the back of your mind that there is an increased risk for hypertension later on in life in adults who had unilateral renal agenesis. Ultrasound findings are similar. I would add one important part is that you will see one renal artery rather than two that confirms that diagnosis. And you follow that aorta down. If it doesn't give any other aberrant arteries implying a pelvic kidney, then I think you can make your diagnosis. And here you see again flat adrenals in the presence of unilateral renal agenesis. How about an ectopic kidney? So an ectopic kidney is a kidney that did not migrate all the way up to the renal fossa. Most common location is above the bladder, as you see right here. And these are not easy to see. So what you look for an empty renal fossa, but the contralateral kidney is not increased because with unilateral renal agenesis, the contralateral kidney has some hypertrophy and becomes larger. Common location is superior to the bladder, but could be anywhere and could have variable blood supply. So here you see clear kidney right superior to the bladder with an empty renal fossa. Color Doppler is helpful because it shows you the kidney superior to the bladder, and you see all these blood vessels coming from branches to provide blood supply to that kidney. You could see it in the first trimester too. It is really difficult though, but you do. Here you see a normal kidney location and you see a pelvic kidney low, and then you see a flat adrenal here compared to a triangular adrenal on this side. So this could be diagnosed early on. Here's a case we had with a thoracic kidney. Here you see the kidneys that is actually in the chest in a patient that we suspected had unilateral renal aplasia early on. So keep that in mind. They could be anywhere, but this is rare. How about horseshoe kidneys? Horseshoe kidneys are kidneys that actually fuse at the lower pole, as you see right here. That's called the isthmic area of the kidneys. What typically happens is they fuse early on in development, and as they migrate up, they get stuck by the inferior mesenteric artery, so they are located typically under the inferior mesenteric artery. The most optimal view to make this diagnosis is by the coronal view, because what you will see on the coronal view is you see renal tissue over the spine, and you should never see renal tissue over the spine on coronal views. Also, you will have multiple renal arteries as you look at that. So if you look at this image right here, this is a coronal image. Look at that. I have renal tissue that is crossing over the midline here, the same here, and that is diagnostic for horseshoe kidney almost always if you see that. And you can see that in the first trimester at 13 weeks here, showing you a horseshoe kidney that is actually over the spine in the coronal view. Cross-fused renal ectopia, meaning that the kidney from one renal fossa had migrated to the other. They are not over the spine, they're not in the midline, but they're totally on one side. They have a fairly associated anomalies as you see here, and the etiology could be many reasons. The key here is that the ureter inserts normally into the bladder. So what you see on ultrasound, an empty renal fossa on one side, a large appearing kidney that doesn't look like a duplex kidney, and at least two renal arteries. Typically, you have multiple renal arteries, and when you look coronally to differentiate this from horseshoe kidney, you don't see any renal tissue over the spine on coronal view. That now ectopic kidney may be complicated by cystic dysplasia also, if that is the case. So here's a case of cross-fused renal ectopia. It's a very large kidney. Look how many renal arteries there are here. Because remember, there's double kidneys in one and sitting on one side. Let me discuss briefly multicystic dysplastic kidney before I go into the adult and the autosomal recessive and dominant cystic kidney disease. Here you have an abnormally functioning kidneys. So all the renal tissue is replaced by cysts. This could be caused by many reasons, primarily obstruction early on, hence the overlap between different categories as I showed you with the classification. Most of the time they're unilateral. When they are bilateral, as you see in this fetus right here, that's really a very poor prognosis, right? This is like bilateral renal agenesis, if you will. There's usually oligohydramnios and complications. 75% of the time are unilateral, as you see here. On ultrasound, what you see is you see bright echogenic appearance of the kidney, especially the parenchyma, because there's accentuation of ultrasound beam from the cyst and their compression of the cyst to the parenchyma. There's no renal pelvis, and these cysts commonly do not communicate. And here with inverse mode, you see that the cysts don't communicate. Sometimes the cysts are peripherally located. That's probably an obstructive nature that happened really early on. So, and these are ultrasound findings. So, small to absent renal artery with abnormal Doppler. This is an important differentiation from an obstructive kidney who will have, the kidney will have a normal renal artery from a multicystic dysplastic kidney where on color Doppler, you will see a fairly small blood supply or even no blood supply coming to it. There's temporal change over time. 35% have extrarenal anomalies, and when they have extrarenal anomalies, they have associations with aneuploidy. Keep in mind, look at the contralateral kidneys because in about 1 in 4, there are issues related on the other side, primarily UPJ obstruction or reflux, as you see in these patients. What is the long-term outcome of multicystic dysplastic kidney? Most of them involute over time. There's increase in hypertension and tumors for those patients who have that. However, in the past, we used to, or at least pediatric urologists used to recommend to remove all these multicystic dysplastic kidneys because of the risk for cancer or hypertension. Evidence, more contemporary evidence has suggested that that is not needed, and elective nephrectomy is no longer routinely performed on those patients. Keep in mind, there is a small risk of chronic renal failure in those patients. Now, if you have a large hyperechogenic kidney, what do you do? What do you manage those patients? This is not an uncommon finding, actually. So here's a list. I put this table. It's really actually, sorry, I did not reference the study, but I put the table here. This is prenatal diagnosis, I think 2011. I put the table here to show you what are the differential diagnoses. So multicystic dysplasia, obstruction. I'm going to talk about these two here, the autosomal dominant and recessive kidney disease. Then we're talking about syndromes that I'm not going to cover in the interest of time. Trisomy 13, especially in the first trimester, and nephrocalcinosis. Here's a fetus with trisomy 13 with echogenic kidneys. Here's a fetus in the first trimester with Meckel-Gruber, and this is an abnormal kidney right here associated with adult onset polycystic kidney disease. So these are the two defects in terminal maturation. Here where the kidneys have formed, but then there's issues related to some of the genes that resulted in abnormal maturation of the kidney. There are two important ones, autosomal recessive polycystic kidney disease and autosomal dominant polycystic kidney disease. How do you differentiate between the two? Here's the key difference. The autosomal recessive polycystic kidney disease, the cysts originate on pathology, if you look under the microscope, from the collecting tubules only. And the rest of the nephron is actually normal. And what you see on ultrasound, you cannot see the cysts on ultrasound because they are really very small. Whereas in autosomal dominant polycystic kidney disease, the cysts are present throughout the nephron, both on the collecting tubules and on the inlet. And there's fewer larger cysts that you see on ultrasound. 1 second. Okay, so autosomal recessive polycystic kidney disease, incidence and pathogenesis, it's a single gene disorder. To my understanding, they have not mapped the location, but they know what causes the disease. It's on the chromosome 6p12. It's responsible for the protein fibrocystins that causes numerous small cysts to form in the collecting tubules. What you see on ultrasound, enlarged hyperechoic kidneys, as you see right here. Loss of corticomedullary differentiation. If you look at this kidney, I can't see the calyceal systems. That's really important in differentiating this from the autosomal dominant polycystic kidney disease. They're difficult to discern the calyceal systems. There is no bladder or absent bladder. It could be small or absent. Oligohydramnios in almost all those cases, but not all. And you could see that in the first trimester. So here's autosomal recessive polycystic kidney disease. In a previous pregnancy at 25 weeks diagnosed, the patient comes pregnant again at 12 weeks. In the subsequent pregnancy, there's increased echogenicity. Genetic workup shows the presence of autosomal recessive polycystic disease. You can test for those prenatally if you have information about the family and you have information about the prior pregnancies involved. Prognosis, these really variable phenotypic expression. Here have to be careful as you counsel those pregnancies. Not all of them are associated with neonatal death. There seems to be two two main outcomes. Those that are, and the majority that we see prenatally, end up with neonatal death after birth. But those that survive the neonatal period have actually can live for a long time. They have complications such as severe hypertension, hepatic fibrosis, and they end up with esophageal varices and recurrent infections. Autosomal dominant polycystic kidney disease is fairly common. The mutations have been mapped to the PKD1 and 2 genes on chromosome 16. Most of the patients have the PKD1. PKD2 is less severe. Here you have large cysts that you can see on ultrasound. So that's a major difference between the autosomal dominant or the autosomal recessive. So as you see here on these fetuses, you see the cysts. Sometimes you see one or two cysts. And here you can see the calyceal system. So that's the difference also. A large kidney where I can see the calyceal system is more associated with autosomal dominant than autosomal recessive. What happens with those pregnancies is the disease is expressed in the 40s or 50s, and typically hypertension and renal failure. So on ultrasound, in large echogenic kidneys, individual cysts may be visible, as you see right here. The calyceal system typically is visible, as you see in this fetus here. There's normal fluid, normal bladder. And here you scan the parent's kidneys, and typically they have fairly large cysts and large kidneys bilaterally. You can start seeing echogenesis. I searched really our database to see if I can find any cases of autosomal dominant polycystic kidney disease that we diagnosed in the first trimester, because we knew the parents had the disease. And I really could not find a diagnosis as earlier than 16 weeks. So I don't know if it exists. I don't think it's been reported in the literature. It's uncommon to see echogenicity in those fetuses as early as 16 or 14, 15, 16 weeks. Here's ultrasounds of autosomal dominant polycystic kidney disease. Here with a grayscale, you see very large kidneys that fill the abdomen. You see the calyceal system around, and there's some peripheral cysts that you see here. And there may be one or two cysts prenatally. Multiple renal arteries is not uncommon in those pregnancies. Prognosis, usually asymptomatic until the 5th decade, as I indicated. They present with hypertension, end-stage renal failure, and accounts for about 10 to 15% of renal dialysis or transplant. So it's a fairly common, 1 in 1,000 is a fairly common disease, and certainly is important to understand the pathophysiology of this. The question becomes how important it is to make the diagnosis prenatally. This is really an ethics issue, a question, because if you make the diagnosis and you label the child as carrier of autosomal dominant polycystic kidney disease, how do you impact the life and outcome of that child with regards to insurance coverage and all that comes with that? So that's a discussion for another day, but just keep that in mind as many times we make these diagnoses prenatally without knowing the significant impact that it has and whether it would make a difference or not at this stage, I'm not sure. So let me bring everything together and kind of conclude with some key points. So understand the spectrum of renal abnormalities and the overlap that exists between entities. Learn the new UTD classification. Remember that normal amniotic fluid volume is only present after 14, 15 weeks, and that comes from the kidneys. Before then, it's from the membranes. There is complexity in patient counseling. Many renal diseases have variable expression. So I showed you that even with autosomal recessive polycystic kidney disease, there are some that survive. And so keep that in mind as you counsel patients. When it's isolated in general, the outcome is good, but bilateral renal anomalies carries guarded prognosis. And when we deal with posterior urethral valve issues, I think it's very complex to counsel those patients because we still do not know that our intervention is making really a difference, and hopefully cystoscopy will improve things, but I think more data is needed. So let me stop here and I think see if you have any questions.
Great. Dr. Abuhamad, thanks for a great talk, good review on that imaging. I'll invite anyone to type in questions or indicate that you have a question by raising your hand by the little hand raising icon at the top of the screen. And you can ask a live question. Dr. Abuhamad, while we're waiting for questions, do you have any data on when you would expect that amniotic fluid should not be attributable to sort of transplacental passage? I know you talked about how after 13, 16 weeks it should be made by the kidneys, but if you still see fluid at 16 weeks in what looks like a classic bladder outlet obstruction, would you question that diagnosis, or you think that still may be sort of transplacental?
So at least based on my understanding is urine production picks up by the fetal kidneys, amniotic fluid production picks up by the fetal kidneys after around 14, 15, 16 weeks. And if you follow posterior urethral valves from the first trimester, typically you start seeing oligohydramnios around 16, 17, 18 weeks in those pregnancies. But it's not absolute, because I think the switch is related to, there's some overlap. So what I see is, certainly if I have the diagnosis suggestive of luto in the first trimester, I follow up those patients. And if I still have normal fluid around 18 weeks at the time of the anatomy ultrasound, then I'm starting to think about other diagnoses rather than an obstructive process. And here talking about prune belly syndrome, you're talking about microcolon stop. So I'm trying to shift my diagnosis beyond posterior urethral valve. But however, there are some partial posterior urethral valve cases that have been documented even in adults and diagnosed in adults. So there's a lot of overlap, and I think I would be cautious in that. But certainly the presence of normal amniotic fluid, in my estimation, is not.
So McGee asks, can you explain how the therapeutic effect from cystoscopy differs from that of shunting? What's the biggest difference in the procedure that could explain the better outcomes?
Yeah, very good question. Yeah, very good question. I do not know. I suspect, however, that that when you put vesicoamniotic shunts, many times you have to revise them 2 or 3 times in pregnancy. I think they get clogged, they get pulled out by the fetus. So I suspect maybe is related to that, and certainly relieving the obstruction directly by cystoscopy may cause the bladder to contract and fill and contract better than with shunt. I'm theorizing. I really do not know the main cause. But certainly if the cystoscopy worked from the first time, and there are need for revisions in cystoscopies also, but if cystoscopy worked for the first time and relieved the obstruction, I think the complications of the procedure itself with vesicoamniotic shunt and repeating it would be gone. So, but I do not know, I don't think it is known why fetuses tend to do better with that.
The follow-up question to that is the cystoscopy through the urethra.
It is through the bladder. So it is actually going through the bladder, putting the scope inside the urethra, and then internally from the bladder side is lasering the obstruction. And the advantages of cystoscopy also over vesicoamniotic shunt, and cystoscopy have been shown to actually provide more accurate diagnosis with regards to, is this posterior urethral valve, is this urethral atresia, is this urethral stenosis. So all these things are resolved better by the cystoscopy, studies have shown, than by the vesicoamniotic shunt. Okay.
Well, I want to thank you again for joining us today. Another great talk. Remember, everybody, first and third Wednesday of every month for a fellow lecture series. We'll see you all again in a few weeks. Dr. Abuhamad, thanks again for joining us today.
My pleasure. Thank you. Bye-bye.
Dr. Abuhamad, thanks for a great talk, good review on that imaging. I'll invite anyone to type in questions or indicate that you have a question by raising your hand by the little hand raising icon at the top of the screen. And you can ask a live question. Dr. Abuhamad, while we're waiting for questions, do you have any data on when you would expect that um, amniotic fluid should not be attributable to sort of transplacental passage? I know you talked about how after 13, 16 weeks it should be made by the kidneys, but if you still see fluid at 16 weeks in what looks like a classic bladder outlet obstruction, would you question that diagnosis, or you think that still may be sort of transplacental?
So at least based on my understanding is urine production picks up by the fetal kidneys, amniotic fluid production picks up by the fetal kidneys after around 14, 15, 16 weeks. And if you follow posterior urethral valves from the first trimester, typically you start seeing oligohydramnios around 16, 17, 18 weeks in those pregnancies. But it's not absolute, because I think the switch is related to, there's some overlap. So what I see is, certainly if I have the diagnosis suggestive of luto in the first trimester, I follow up those patients. And if I still have normal fluid around 18 weeks at the time of the anatomy ultrasound, then I'm starting to think about other diagnoses rather than an obstructive process. And here talking about prune belly syndrome, we're talking about microcolon top. So I'm trying to shift my diagnosis beyond posterior urethral valve. But however, there are some partial posterior urethral valve cases that have been documented even in adults and diagnosed in adults. So there's a lot of overlap, and I think I would be cautious in that. But certainly, the presence of normal amniotic fluid, in my estimation, is not an indication for intervention.
So McGee asks, can you explain how the therapeutic effect from cystoscopy differs from that of shunting? What's the biggest difference in the procedure that could explain the better outcomes?
Yeah, very good question. I do not know. I suspect, however, that that when you put vesicoamniotic shunts, many times you have to revise them 2 or 3 times in pregnancy. I think they get clogged, they get pulled out by the fetus. So I suspect maybe is related to that, and certainly relieving the obstruction directly by cystoscopy may cause the bladder to contract and fill and contract better than with shunt. I'm theorizing. I really do not know the main cause, but certainly if the cystoscopy worked from the first time, and there are need for revisions in cystoscopies also, but if cystoscopy worked for the first time and relieved the obstruction, I think the complications of the procedure itself with vesicoamniotic shunt and repeating it would be gone. So, but I do not know. I don't think it is known why fetuses tend to do better with that.
The follow-up question to that is the cystoscopy through the urethra.
It is through the bladder. So it is actually going through the bladder, putting the scope inside the urethra, and then internally from the bladder side is lasering the obstruction. And the advantages of cystoscopy also over vesicoamniotic shunt, and cystoscopy have been shown to actually provide more accurate diagnosis with regards, is this posterior urethral valve, is this urethral atresia, is this urethral stenosis? So all these things are resolved better by the cystoscopy, studies have shown, than by the vesicoamniotic shunt. Okay.
I want to thank you again for joining us today. Another great talk. Remember, everybody, first and third Wednesday of every month for a fellow lecture series. We'll see you all again in a few weeks. Dr. Abuhamad, thanks again for joining us today.
My pleasure. Thank you. Bye-bye.